Welcome to ModPath Chat, the official podcast of Modern Pathology, featuring interviews with authors and experts on the latest science, technology, and developments in the field of pathology. Our host, Dr. George Netto, is the editor-in-chief of Modern Pathology and professor and chair of pathology and laboratory medicine at Perelman School of Medicine at the University of Pennsylvania. Here's Dr. Netto.
Happy New Year, everyone. This is our first podcast of the year, and we picked the right guest for it. It's Dr. John Hart, professor and vice chair of Anatomic Pathology at University of Chicago. John doesn't need an introduction. He is the immediate past president of USCAP. He's been a past president of everything. Past president of Roger Hadget Society for GI Pathology, If I love a lot of things about John, and I admire a lot of things about John since I've been a junior faculty. I think being an educator and a mentor is probably one of the things he prides himself on, in addition to being one of the best GI pathologists in the country. He trained at least 30 fellows. He started the fellowship there, and they're all over, and they're making a difference. And he'll share with us some anecdote about one recent fellow. So it gives me a lot of pleasure to welcome him to talk to us about a recent critical study that he's done, published with his team. It's a multi-institutional study in modern pathology. So welcome, John, and thank you for everything you've done for USCAP and for modern pathology.
Well, thank you, Dr. Netto. It's really a pleasure to be here, and I love this opportunity to speak about a project that I really enjoy doing. And I'm grateful that it was published in Modern Pathology, which is a journal that I have always loved, and it's always a thrill to be published in that journal.
We appreciate all the support and engagement and investment you gave to the journal during your tenure, and you will continue to. So let's dig in. I think this is one of these studies that we love the conclusion of, because it's going to make a difference in how we should be doing things. So tell me, what was the why? Why exactly now you're doing this heavy morphology-based study, which is another great thing about it.
I love this kind of project. It's great to have groundbreaking molecular project and forge new grounds. That's a lovely thing to be involved in, of course. But also, in addition, are these kind of projects, which are answering a question that comes up repeatedly in daily practice as you're over the scope, just again and again, and you're always like, someone should do this study. And that's how kind of the origin of this study. So we were looking, actually, I'll go back. I was on a panel discussion in 2019 for the Crohn's and Colitis Foundation, which is always a great opportunity for a pathologist to get to speak to our clinical colleagues rather than, all pathologists. So it was gastroenterologists and surgeons, and it was mostly about IBD and dysplasia, but I kind of in passing said, please don't biopsy the anastomosis in your Crohn's disease patients, because we never know what to do with those. And an immediate murmur went through the entire crowd. And then it was on Twitter that Dr. Hart says, don't biopsy the anastomosis. And it kind of blew up a little at that point. I didn't have any real data at that point to share with them, but it was simmering in the back of my mind. Then a couple of years passed, and then a former fellow, Lucas Campbell, who's now the president of his pathology group down in Arkansas, and a former resident of Laura Lamps, another famous GI pathologist, called me, or texted actually, both Laura and I, and said, what do I do with these Crohn's disease biopsies where they're biopsying the anastomosis? Is it just post-surgical change, or does that represent active Crohn's? You guys should do a study on that. And so back and forth between Laura and I and Dr. Campbell. And in the end, that's how this study originated. The next step was to get my new incoming fellow,
exactly.
Right, to work on the project, because as you know, the abstract deadline for USCAF is in October, and Dr. Yantis has done a great job in making that, pushing that back as far as it can be.
Uh-huh.
It doesn't give much time for new incoming fellows to generate a project. So Dr. Greta Evaristo, who was at McGill and was going to be my fellow, I contacted her that day after talking with Laura and Lucas. And I said, we need to start this project. And she jumped on it. She is an amazing young GI pathologist, a resident at that time. She got her mentor, Dr. Marcus, involved, and one of her colleagues, a resident there. And then Dr. Lamps got her fellow involved in the project at the University of Michigan, and we all collected cases. So the idea of this study is we're going to compare the patients who've had surgery for Crohn's and look at their biopsies from the anastomosis and compare them to patients who had an anastomosis who never had Crohn's, who had diverticulitis or colon cancer, but had a surgical resection. And it's amazing that the gastroenterologists, they cannot resist the temptation to biopsy right at that anastomosis. That's always a little bit eroded or inflamed or indurated or at least erythematous. And they consistently make that biopsy. And in a Crohn's patient, as I said, you're just not sure, is this just simply reflecting post-surgical state? Or is it a facet that is due to the Crohn's disease? Does it represent reactivation of their Crohn's? So that was kind of the question we were getting at.
Wonderful. And I love the story behind the story. And I love how always the fellows and do the work and our senior, including myself, don't hesitate about taking the credit.
Exactly right.
Exactly. So, but they owe us.
Yes. The whole project I gave Dr. Evaristo was, let's compare the Crohn's anastomotic biopsies to the patients who had surgery for something else. That was the whole project. And she took that short statement and made it into a really cool, she thought very deeply about it, much more deeply than I had ever in those years thought about it, and came up with a really good project, well-defined, as you said, multi-center, good cohorts, and powerful enough to answer the question that we were getting at.
Perfect. So it is around, if I remember correctly, 208 total from 3 institutions, and 109 of them were from actual anastomotic biopsies from actual CD patient, Crohn's disease patients, and then the remaining were not. And so tell us a little bit, what did you look for? And I realize there is a clinical criteria or classification background that would be great to share with our audience, pathologist audience, especially.
Right. Yeah, because not everyone listening, I know, is loves Crohn's disease as much as we do. But
so take a special kind of people to be
right. Yeah. So here's the background. So when a patient undergoes colectomy for UC, they're essentially cured of their UC. That's it. At least that's done. There's extra intestinal manifestations, of course, but they're done with their UC. It's unfortunately not true of Crohn's. So in Crohn's disease, about 50% of patients have to undergo a resection. And after their resection, about 80% of them, unfortunately, will have endoscopic recurrence within 10 years after their resection, or 5 years after the resection. And about 50% of them will have symptomatic recurrence. And that's soul crushing to, go through that surgery, but knowing that there's a high likelihood that you're going to have recurrence. There are clinical features that increase your risk of recurrence. Things, smoking is the strongest of those. It really exacerbates Crohn's disease, so they really caution patients who are undergoing surgery to try to quit smoking if at all possible. But there are a number of other factors that increase your risk. But that said, there's a strong likelihood that you're going to recur with Crohn's disease after going through this surgery. So the question is, what can we do about that? What can the clinicians do about that? And there are prophylactic therapies that are given after the surgery. Long-term maintenance therapy on metronidazole has traditionally been what's given to everyone. That's a hard thing to stick to. Lots of side effects that are make it almost impossible to stick to that therapy. But since then, in the last few years, we've kind of moved to anti-TNF treatments like infliximab. Those agents are given prophylactically after surgery, particularly in high-risk individuals, to try to reduce the risk of symptomatic recurrence. So another strategy then is to surveil the patients, and that's what's going on here. The gastroenterologist after surgery starts doing every 6 months or every year endoscopy to see if there's early signs of recurrence. And then they always take that endoscopic biopsy. So that's kind of the clinical background. And, if we call it active Crohn's disease, then they're going to escalate the therapy. On the other hand, if the changes are really just post-surgical, you wouldn't need to do that. So that's what the study was kind of aimed at. So what we found, in fact, that there was a considerable overlap, that patients who never had Crohn's disease, when they got those biopsies from the area of the anastomosis, they often showed histologic features that we use as indicators of Crohn's disease, things like basal lymphoplasmacytic infiltrates, of course, ulceration and active inflammation, but even pyloric gland metaplasia, which we traditionally think is a strong indicator for Crohn's histologically, can occur in any post-surgical situation. Of course, we've known that for years because we can see pyloric metaplasia even in NSAID ulcers, chronic NSAID ulcers. So it wasn't entirely unexpected that we would see considerable overlap between our two cohorts in terms of those histologic features.
In the anastomotic biopsies.
In anastomotic biopsies. Now, what the key thing that Dr. Evaristo added to the study was the examination of any biopsies taken away from the anastomosis. That turned out to be very valuable information. And in our multivariate analysis and in the individual data analysis that took place, what we found is it was those biopsies that actually were predictive of clinical escalation of clinical symptoms, the development of clinical symptoms, and the necessity to escalate therapy. So that was the important biopsies, and the findings in those biopsies are what are important for clinical management of the patient. And the biopsies of the anastomosis, in contrast, just are not really valuable indicators for clinical management.
And just to clarify about the cohort, my understanding is the one that are non-CD patients, these are patients who had the surgery for either a colon cancer or a diverticulitis or diverticular disease, correct? So they had nothing to do with UC or any inflammatory bowel disease, and hence the overlap is totally due to the mechanical or ischemic or whatever change in that anastomotic side. Is that correct?
Yeah. Yes, that's correct. And I think most pathologists who do a little bit of GI kind of have that as their thought going in as they're reading a study like this. We see anastomotic changes at other sites in between the stomach and the esophagus, or the stomach and the small bowel too, and the same kind of inflammatory, chronic and active inflammatory changes near an anastomosis.
Including even crypt architecture. I'm sounding very smart because I read the study. For a geopathologist, sounds great to me. It's even the distortion, even the Panette cell metaplasia. It's just it's good to know that you agree with that. And so the take-home message, you think this is really gonna lead to another, hopefully, tweetosphere kind of storm, saying to all GI doctors, stop biopsying that anastomosis side?
I do think it's, I hope so. And it does bring up a point that both of us know, and that is this constant dialogue with your clinicians is really the key. For a tumor case, maybe not so much. It's pretty cut and dry. But for inflammatory conditions, infectious things, anything non-tumor, non-neoplastic, it's not always just what's on the page. It's a dialogue between you and the clinical team to make the patient care as best it can be. So continued dialogue is going to be important. We had an outstanding clinician as a co-author on this paper, Dr. David Rubin, who's the chief of GI gastroenterology at the University of Chicago. He's an international renowned expert on inflammatory bowel disease. That's his central interest. And so having him as a co-author, he can spread the word at his clinical meetings as well. And he's wants to follow up this study with additional prospective studies to reinforce our message.
Wonderful. So the message is, no, don't do it. It's not useful. It's not going to help you. But the other biopsies from non-anastomotic sites remain predictive and help prognosticate and guide management.
Yeah, I think that, in my own practice, what I've done is the anastomotic biopsies, I don't call them Crohn's disease. I describe the features and I don't call them Crohn's disease. Whereas in the other biopsies, if any are taken, I then would call those active Crohn's disease. So that's kind of the take-home message for practicing pathologists out there, that even if you see features that are pretty good for Crohn's disease, if you know it's taken from the anastomosis, you want to avoid using the term active Crohn's disease for those biopsies.
Beautiful. I really enjoyed the study and enjoyed the conversation. But we're going to do a little trailer for the long course now. We're gonna have the opportunity, actually, for the first time in USCAP in the exhibition center. We're gonna be doing a podcast about your long course together with Daniela and Lindy, which promised to be. So can you give us, just without spilling too much beans, but entice people to register also for the long course, and what you anticipate there, and why one should register for that?
Right. Thank you for this opportunity.
This is free advertisement.
This is great. So I'm so excited to be the director, along with Dr. Rolandi from the Cleveland Clinic, who's the co-director of the long course. So please consider, as you're making your travel plans, to stick around until Wednesday for the long course. It's a liver long course, and it's devoted to where molecular can be of value for the routine sign out of both neoplastic and non-neoplastic liver cases. So this is intended for the general surgical pathologist who encounters liver biopsies, but it's going to be looking forward to the day where we're constantly integrating our molecular testing into our reporting of both non-neoplastic and neoplastic cases. So we're going to cover a variety of topics. We have international experts from Europe and Asia and from the United States, and we're going to cover the full spectrum of liver diseases, and we're going to start always with the H&E and then say, based on the H&E, where are the situations where you can leverage molecular findings? Where can they really make an impact in clinical management for the patient? So I hope anyone who is attending the meeting is going to be great in Baltimore. I've already heard really exciting plans for the Baltimore meeting. And I invite everyone to come and have a great time. And let me just end by saying one last thing. I know I'm going over time, but
no, not at all. It's all yours.
This project is the perfect illustration of what I love about USCAP in general, and that is a project where it's something that starts over the scope, and then you have a really eager and capable resident, or in this case, fellow, who takes on the project, molds the project, takes it on as her own, and then you involve your other friends and colleagues that you know who are equally interested in something like this. You get that abstract submitted, which is always excruciating yet fun. Then you hang around waiting for Dr. Yantis to give you that notification. Plan your meeting, get into the room or into the exhibit hall and present your finding. And that is such a crucial part of it, because those conversations with your colleagues allow you to think more deeply about things. A lot comes out of that interaction at USCAP every year. Go back, and then if you have a great fellow like Dr. Evaristo and her colleagues, I should mention the other colleagues, her mentor, Dr. Marcus, and her resident colleague, Dr. Farag, and Laura Lamps and her fellow, Dr. Sinspansky. They finished up the manuscript, got the manuscript, and then a manuscript like that, where the abstract is presented at the meeting, deserves to go to, for consideration at least, to Modern Pathology. So I love working with Modern Pathology. The editorial staff there is great. The portal is just perfect, streamlined, works like a charm, easy to work with, great fast turnaround time, and then published in Modern Pathology. Wow. That's why I like being an academic surgical pathologist. That process just is so exciting. So I love it. So thank you, Dr. Neto, for our paper, and thanks to the editorial staff in Palm Springs as well.
Yeah, it's thank you for the payback. We pride ourselves on authors like you and your team, and we're so glad it worked out. And this study really, from beginning to end, has the name USCAP all over it. So thank you very much. And like I mentioned in the beginning, now the audience really see your passion about educating and training and mentoring and making discoveries. It's been a pleasure, and thank you for all your service and for more years to come, both for the journal and USCAP. And see you in Baltimore.
All right. Thank you very much. Bye, everyone.
Any opinions expressed in this podcast are the speaker's own and do not represent the views of Modern Pathology, Elsevier, the University of Pennsylvania, or USCAP. Your ModPath Chat host and scientific director is Dr. George Neto. The producers are Dr. Catherine Ketchum and Carly Hess. Technical direction is provided by Kaminsky Productions. Music by Mitch Neubauer. Thanks to the authors, reviewers, and editors of Modern Pathology for making this podcast possible.